Thank you so much, sir. So now we would invite Dr. Shaloo. Dr. Shaloo Bageja, as I said, is a consultant in oculoplasty at Gangaram Hospital, New Delhi, and she'll be speaking on distichiasis and trichiasis. Timer 10 minutes का लगाइए, आपके 5 minute का timer लगा हुआ है, please.
Good afternoon, everyone, and I'd like to thank Dr. Ruchi for including me in our course. So I'll be basically discussing the distichiasis and trichiasis. Excuse me, this is not moving. So distichiasis, we all know, is the aberrant growth of the lashes from or near the meibomian gland orifice, while trichiasis is the normal position of the lashes, but they are misdirected towards the ocular surface and not moving, please. So distichiasis can be congenital or acquired. However, trichiasis is mostly acquired in nature, and congenital distichiasis is most frequently inherited as autosomal dominant condition, which is associated with systemic lymphedema due to abnormality of FOXC2 gene. However, the acquired distichiasis or trichiasis can occur due to any inflammatory condition following infection, autoimmune disorder, or inflammatory causes. So all these patients present to us mainly with the foreign body sensation, watering, photophobia, and if untreated can have ocular and visual problems. So coming to the management of this distress condition, symptomatic treatment is given initially lubrication in form of drops or gels, and in severe cases we may have to give bandage contact lens to prevent the keratopathy. The choice of the surgical procedure depends on the extent of the lid margin involved and is there any history of previous treatment. So if only few distichiatic lashes are present like this, in an isolated 1 or 2 lashes are present, we can opt for manual appellation with forceps. However, we know the lashes regrow in 4 to 6 weeks. So electrolysis was initially done where the electric current was passed. It causes the lateral heat and excessive scarring of the lids. So nowadays we opt for radiofrequency electrolysis. Laser ablation, diode or argon laser has also been described along with the eyelash definition, which I don't have personal experience. So the radiofrequency ablation gives a good result. In this, after giving the local anesthesia, the needle is passed deep into the lash roots. About 2 to 2.5 millimeter depth should be attained so that we reach the bulb root, and 1 to 2 seconds of 2 millijoule of power, and we see that the bubble appears, and we can remove the lash without any force. And if about segment or half of the lid is involved like this, then we have the treatment modalities of choice like excision of lash root via the trapdoor, or wedge excision in cases of we can do a pentagon excision and reconstruct the lid as in a normal marginal repair, or we can go for cryotherapy. So lid splitting with cryotherapy has the advantage that it does not cause the complication like depigmentation. So we opt for the lid splitting of the 2 lamella and give the cryotherapy. It's a double free thaw cycle is given in the posterior lid margin, and with the help of because of the lower temperature, the bulb of the lash is destroyed and the recurrence rate are less. So as high as 90 to 91% of success rate has been written, and some surgeons prefer to combine it with the anterior lamellar recession also. As I already described, that the cryotherapy can cause the complication like lid margin distortion. So the lid splitting needs to be the integral part of the cryotherapy, so we avoid the depigmentation or the distortion of the eyelid. In case we have recurrent previous failed procedures, or there is the involvement of almost whole of the eyelids, so the basic treatment modality should be the resection of the posterior lid margin. along and replacing it with the buccal mucosa or the tarsoconjunctival graft. Though I have not used the tarsoconjunctival graft, I have used only the buccal mucosa, but the literature says if you have excised much of the tarsus so that you are not sure of the integrity of the eyelid, so you can replace it with tarsoconjunctival graft also. And in case there is a eyelid malposition as in trichiasis, you can go for anterior rotation like tarsofracture or blepharotomy. So in this we do the eyelid splitting and the buccal mucosa is used, and we need a small strip, so we don't need to harvest much of the buccal mucosa. We take as we take from the buccal mucosa, we divide it into two parts and then suture it to the anterior and the posterior lens margin, and we can use the bolster to for the proper hemostasis will be achieved in the graft. This is a small video where we showing the lid splitting. It should be anterior to the distichiatic lashes, so that we take the integral part of the surgery is that all the distichiatic lashes should be removed along with the when we are excising the posterior lamella, the tarsus. So if we leave the lash root, then they may recur. So it's important that we should remove all the tarsus sufficient, so that all the lash roots are removed, all the distichiatic lashes are removed. So once we measure it, we take a slightly larger graft, about 10 to 15% larger graft, and then the lip mucosa graft. This can be undermined and sutured as the size of the graft is not much. And after thinning the graft, we cut it into two halves. We can use the glue also, so that the sutures may rub the posterior corneal surface, so we can use the glue and can have some atovical sutures, so that we don't lose the graft. Just for additional support, we can put the atovical suture also intermittently. This is a small video showing the patient with secretial entropium with trichiasis, where we have done the tarsal fracture so that the trichiatic lashes are moved forward. So in this, with the radiofrequency needle, the full thickness tarsus is cut, and 3 double arm sutures are used for the rotation of the lid. So once we have cut the whole tarsus, we do the slight undermining so that we can enable the rotation of the lid properly. And we are using a 5/0 silk suture, which is passed from the distal end and then coming out below the tarsus near the lash root. So once we tighten it, it causes the rotation of the eyelid margin. The pass to the sutures over the bolster, and is kept for 2 weeks. And then after 2 weeks, we can remove the bolster. So the 3 sutures are passed like this, double arm sutures are passed, so that we have a adequate rotation of whole of the eyelid. So this is just the pre and the post-op picture of the patient. So the electrolysis is a non-surgical management which we can use for the small, the isolated lashes, and cryotherapy can also be used as the most frequently used modalities. But however, they have a recurrence rate of electrolysis is believed to have a recurrence rate of, with radiofrequency it has a 60 to 70%, and cryotherapy is about 80% of recurrences. But if there is a recurrent lashes are appearing, and if the whole of the lid is involved, then it's better to do the lid splitting along with the excision of the posterior marginal strip and replacing it with the mucous membrane graft, which give us the good results and long-standing results. Thank you.
So thank you, Dr. Shaloo, for the beautiful videos that you have shown. And I would agree that actually lid splitting and putting a mucous membrane graft is much, because cryo, I don't know, I don't find it a very useful procedure. I don't know what sir has more experience.
For localized ones, it works.
It works. But recurrences do occur.
If there are occasional here, then you do a R. But if you reduce them by 80%,
So
you don't always have to do a graft in smaller or localized.
yeah, when it's a entire like distichiasis, congenital distichiasis especially, then it
Entire row, then
better to